Hi, my name is Tobias Raupach from Göttingen University in Germany. In this short presentation, I'll give you some background information on a study in which we assess the effect of test-enhanced learning on the acquisition of complex cognitive skills in undergraduate medical students. This is the outline of my presentation. First, I refer to the relevant literature that formed the basis of our own study hypothesis. Following a short description of the study design and the methods we used, I present some key results. Finally, I'm going to summarize what we found, and on the final slide you'll find a number of questions aimed at stimulating our discussion in the flipped classroom session at this year's AMEE Conference. These little boxes in the upper right-hand corner of my slides refer to the presentation outline, so you always know which section of the presentation you are currently watching. You may also use these boxes to navigate to those sections you find most interesting. To get started, let's just recap some important definitions so we can all use the same terminology when discussing the study at the conference. Our current trial was based on previous work in which we assessed the impact of examination consequences on student learning behavior. In this context, it is important to distinguish between summative and formative exams. Summative exams are graded. Students can pass or fail them. In medicine, they allow an overall judgment about competence, fitness to practice, or qualification for advancement to higher levels of responsibility. As opposed to summative exams, formative assessments are usually not graded, and students cannot fail them. One of their functions is to provide students with feedback in order for them to identify potential areas of improvement. This is the study I just referred to. It involved 4 consecutive cohorts of medical students at Göttingen Medical Center for a total sample size of over 500. Fourth-year undergraduate medical students enrolled in a 6-week cardiology module were randomized to 3 different instructional formats in order to learn how to read an ECG. Some students were asked to self-study an ECG interpretation guide, practice how to read an ECG, and compare their results to expert interpretations that were available online. A second group of students received 8 lectures on ECG interpretation, and the same tracings that had been used for self-study activities in the first group were now being discussed in the lecture theatre in the presence of a cardiologist. Students in the third group attended 8 small group teaching sessions led by peer teachers. They discussed the same ECG tracings as the other 2 groups, but obviously this teaching format was much more interactive. We expected peer teaching to be much more effective than the other 2 formats. At the end of the module, each student took a written test on ECG interpretation skills, but this exam came in 2 forms, in that students were randomized to take either a formative or a summative exam. As you can see, all students who had been informed that the ECG exam would be summative, down here, achieved similar scores regardless of instructional format. In the context of a formative exam, however, peer teaching did in fact appear to be more effective than lectures and self-directed learning. In a logistic regression analysis including both teaching format and exam consequences, the only significant predictor of student performance in the final ECG exam was whether this exam was summative or formative, as you can see here. We took this result as evidence of the well-known axiom, assessment drives learning. This impact of exam consequences on students' learning behavior is also called the indirect testing effect. As discussed in the previous slide, summative assessments have a huge impact on student learning behavior. However, it has been known for quite some time that being tested also has a stimulating effect on learning processes. In fact, every successful attempt to retrieve information from memory increases the chances of being able to recall that information again later on. This phenomenon is called the direct testing effect, and I'd like to recommend this excellent overview article to those of you who'd like to know more about its history and its theoretical underpinnings. In a nutshell, testing material that has already been learned is generally more effective than restudying the same material, Activities involving repeated testing and aimed at enhancing long-term memory are usually being referred to as test-enhanced learning. Since 2008, a number of research articles on the effectiveness of test-enhanced learning have been published. This is an example of a study addressing the acquisition of factual knowledge. Undergraduate medical students used flashcards to revise their knowledge on renal disease. These cards were either designed to facilitate repeated study by providing 3 relevant bullet points, or to elicit the testing effect by just showing 3 blank lines. Retention of factual knowledge was assessed after 1 week and 6 months. Test-enhanced learning appeared to be effective in the short but not the long run. Please note that overall performance levels of these students was at best moderate. While that first study focused on factual knowledge, this one assessed whether the direct testing effect does also work for the practical skill of cardiopulmonary resuscitation. 140 undergraduate medical students who were enrolled in an in-house resuscitation course were randomized to receive either a full 4-hour training course or just 3.5 hours of training with an additional 30 minutes of being tested. 2 weeks later, retention of practical skills was better in those students who had been tested during the final 30 minutes of the course. And this effect was almost maintained 6 months later. Please note that in this study, teaching time was identical for both groups. This is important as some researchers have challenged the retrieval hypothesis underlying the testing effect. They have proposed that superior performance in students who have been tested is simply due to the fact that they have spent more time looking at the material. This does seem plausible, as taking a test usually takes longer than just restudying the material one is supposed to learn. By keeping exposure time constant, these authors provided evidence in favor of the retrieval hypothesis as opposed to the total time hypothesis. I hope these explanations have helped to set the scene for the discussion of our own current study. Given that test-enhanced learning works for both factual knowledge and practical skills, we wanted to know whether the direct testing effect can also be used to foster the acquisition of more complex cognitive skills, such as choosing appropriate diagnostic tests, making a diagnosis, and suggesting an appropriate therapy for a given condition. In the overview article I recommended to you in slide number 5, the authors make some helpful suggestions regarding the ideal assessment format. For example, production tests are more likely to elicit the testing effect than recognition tests such as multiple choice questions. Given that the latter do not lend themselves to assess complex clinical skills, we had to identify a more appropriate assessment format. We finally decided to use key feature questions for both the intervention itself and the final performance test. Key feature questions are one well-researched format aimed at assessing a student's ability to correctly identify relevant steps, i.e. key features, in patient management. If you want to know more about key feature questions and the available evidence regarding their use in medical education, please take a look at this excellent review published last year. So, what was our study about? We hypothesized that undergraduate medical students answering key feature questions retain more procedural knowledge over a 6-month period than students being exposed to the same content but without being prompted to answer key feature questions. In order to test this hypothesis, we conducted a prospective, randomized controlled trial using a crossover design. All undergraduate medical students enrolled in the 4th year at Göttingen University Medical Center in winter term 2013 were invited to participate, and 120 provided written consent to have their data analyzed. Students were assigned to one of 2 groups. However, as you'll see in a moment, group assignment was not important as data analysis was performed on the level of individual learning objectives rather than group assignment. On the first day of the module, all students took an entry exam consisting of 30 key feature questions. 15 of these items went on to become intervention items for Group A. This means that during the following 10 sessions of electronic seminars, these items would only be retested but never restudied in Group A, while students in Group B would never be tested on these items but would only have the opportunity to restudy the material. The opposite was true for the 15 items that were used as intervention items in Group B. These items were used as control items in Group A. In each of the 10 weekly electronic seminars, students were presented with 4 case histories. Case content was identical for all students, but the format varied each week between studying only cases or testing cases, which also involved prompts to answer 5 key feature questions per case. Unfortunately, a total of 12 students turned up in the wrong computer room at least once. As a consequence, these students received the wrong intervention, thus giving rise to contamination bias. Accordingly, these students had to be excluded from data analysis. At the end of term, that is 3 months after the entry exam, all students took an exit exam, which was identical to the entry exam. They then spent 3 months on clinical rotations and another 3 months on formal teaching unrelated to internal medicine. 6 months after the exit exam, there was an unannounced retention test during which students were presented with 30 key feature questions. This is what a key feature examination looks like at our institution. Students read a short introduction providing information on the context of the clinical case. Once they click on the Next button, they are prompted to answer the first key feature question by typing a few letters and then choosing an appropriate option from a list of over 4,000 words. After making their choice and confirming the answer, students see the correct answer and they are given additional information that will be needed for the next question. Given the importance of feedback for learning processes, we wrote up specific feedback for each of the 200 questions used. Students were encouraged to check whether they had chosen the correct answer and read an explanation why some answers were considered correct and others were considered suboptimal before proceeding to the next question. The primary outcome of our study was the difference in some scores between intervention and control items in the retention test. As I mentioned earlier, there were 15 control and 15 intervention items in each group. Those items that were retested in Group A were restudied in Group B and the other way round. Data were dummy-coded to arrive at a situation in which there were 15 intervention and 15 control items for each student, and we were able to run a paired t-test for the within-subject difference between repeated study and repeated testing. As explained earlier, exposure time needs to be controlled for in studies on the direct testing effect. We were unable to align exposure time between the two groups for obvious reasons. However, we collected log-on times and included these in linear regression analyses with difference between scores in intervention and control items as the dependent variable, and difference between mean time spent on testing and studying as the independent variable. Finally, we also looked at student performance in the exit exam and analyzed data on the level of individual learning objectives or items. These are the results of our study. As you can see, included students did not differ from those who had to be excluded for the various reasons shown on slide 11. Attendance at electronic seminars was good, and students spent considerably more time in seminars during which they were tested compared to seminars during which they were asked to study clinical cases, hence the need to control for this potential confounder in the analysis. Internal consistency was excellent for the exit exam and the retention test. Overall percent scores indicated that there was a moderate increase in student performance between the entry and the exit exam, and almost no drop in performance over the 6-month period following the exit exam. Let's take a look at the primary outcome now. As expected, repeated testing resulted in superior performance in the exit exam as well as the retention test. The difference in student performance was significant at both time points. The unadjusted analysis revealed a significant correlation between excess time spent being tested and performance in the retention test. However, the adjusted linear regression revealed that when controlling for exposure time, there was still a significant effect of the main intervention on student performance in both the exit exam and the retention test. The percentage of students providing the correct answer in the retention test was significantly higher if a particular item had been tested throughout the previous term as compared to repeated study of the same item. For example, about half of all students correctly identified a pneumonia on a chest X-ray film if they had been trained to do so using key feature questions. Students who had been presented with the same clinical material on the computer screen but without having been asked about it were less likely to provide a correct answer. Only 1 in 5 students provided the correct diagnosis in the retention test. I'll quickly summarize our study before asking a few questions that you might like to discuss during our flipped classroom session at AMEE 2015. As I said at the beginning of this presentation, summative assessments determine learning behavior. Formative assessments can enhance learning processes. In our crossover RCT, exposure to the same teaching material was associated with a significantly better learning outcome when coupled with key feature questions as compared to simply studying the material, even when controlling for exposure time. Thus, implementing longitudinal key feature testing in undergraduate medical education considerably enhances sustained learning outcome on relevant aspects of clinical medicine. These are some questions that I believe might be worth discussing in Glasgow. First, it would be interesting to discuss the cognitive processes underlying the effects we have seen. Another important question is whether the effects seen in this laboratory trial actually translate to clinical practice, to other areas of medicine, and, in fact, to other medical schools within and outside Germany. We might also want to discuss alternative assessment formats that might have the same effect as key feature questions. Finally, in order to move on, we should explore ways of increasing the alignment between the classroom setting and the reality on the wards. One option here would be to use video-based instead of text-based key feature questions. I'm looking forward to discussing these and your questions during our session at this year's AMEE Conference. If you want to get in touch, please don't hesitate to contact me. Thanks very much.